our second speaker is Kim Sueng. He will talk about stimulation for also OCD, and let's welcome speaker.
Hi, my name is Sueng Choi. Unfortunately, the primary author on this work cannot make it here today, so her name is Arba Amir. So I'm going to present instead of her. So today I'm going to talk about deep brain stimulation for obsessive-compulsive disorder, especially how we evolve this tractography-based targeting method. So this is my disclosure. So DBS for OCD, especially ALIC DBS, is very effective neuromodulation treatment for the refractory OCD patient. The ALIC DBS is most widely used and only approved FDA target. However, their response rate is vary 20% to the 70% depending on the center, and also it require long trial and error parameter adjustment. Recent literature, they suggest that white matter tract in ALIC impact the affective and cognitive function underlying OCD and depression symptom. Probably this OCD improvement may correlate with the stimulation of the ALIC connection between the lateral medial prefrontal or thalamus or some of the midbrain structure. So it requires a consistent targeting method and uniform response pattern. Also, previous connectivity analysis from the OCD DBS, there is the two major bundle was identified. One group, they emphasize about the medial forebrain bundle is associated with the clinical outcome, and the other group emphasize about the anterior thalamic radiation bundle. However, these two groups disagree that which one is more important and the other. So before I go into the detail of the current study, so what is the connectome-based DBS targeting thing? For the STN or Parkinson's disease or movement disorder, we can easily visualize the STN structure using some imaging method. However, for the psychiatric disorder, there is no clear anatomical landmark for the depression such as SCC, subcallosal cingulate, or OCD, anterior limb of internal capsule ALIC. So for the depression, we established the connectome-based targeting method using the necessary pathway. Previously, we identified the cingulum and forceps minor unsynaptic bundle as necessary to make patient better. So we applied this same concept to the OCD ALIC DBS here. So aim of this study is first, we want to define common responder map. And second, using that map, we want to test in new cohort prospective targeting. And finally, we want to build a tractography-based stimulation model to predict the Y-box score. We did a 13 patient. As a pilot cohort, we used a 3 Tesla DWI imaging from 3 patients. And then we get both 3 Tesla and 7 Tesla data. As a clinical measurement, we measure Y-box, BDI, and BAI score. 3T, we collect 60 direction single cell DWI with a 2 millimeter isotropic resolution, and 70, we do the 128 direction multi-shell and 1 millimeter isotropic resolution. So in this presentation, I emphasize about evolution of how we tractography-based targeting. First, we start from the literature, as I mentioned before, ATR versus MFP. And then we built our data-driven common map, and we use that common map to test in new cohort prospective targeting. Finally, we update our common map for the future subject. Here is some details about tractography analysis. We use a T1, DMRI, and post-op CT, and then we estimate volume of tissue activated with given stimulation setting. From that VTA, we do the whole brain tractography and average all responder connectivity map to generate common map. And then later, we also do the stimulation model to predict the Y-box score using pre-surfer partialization and non-repeated measure correlation, and finally, we can build a Y-box prediction model. So here is at the beginning how we start. We want to utilize a directional electrode at the beginning, and then we put our electrode the middle of the two bundle, ATR and MFP. And when we utilize this directional lead, we can actually steer to the one bundle instead of the stimulating both bundle and the other. However, finally, we got our result that we need the both of bundle to make patient better. So we need to stimulate ATR and MFP. So we change a little bit the approaching that we look at the projection from the ALIC to the prefrontal or some other subcortical lesion, and we found that is the ventral medial frontal and ventral lateral frontal, and the midbrain connection is critical or it's associated with the DBS improvement. So using these three brain lesions, we extract the connection from ALIC. As you see on the right side, the red indicate the ventral lateral prefrontal connection from the ALIC, and purple indicate the ventral medial frontal connection, and yellow indicate the midbrain connection. And we choose the optimal target location, or we put the electrode into the all three bundle confluence together in the spot. So we did this to the next 7 patients. And here is the electrode location at the first initial cohort at the yellow, and the red is the new cohort we tested. And new cohort result is a little bit more medial, and it really ending up together around the GPE boundary area in the ALIC. And this is clinical outcome we have. Overall, we have around 48% mean Y box improvement. And based on the response, more than 35% improvement as a responder, we have an 80% response rate. And not only this improved the response rate, we have a faster and the larger improvement in this new cohort with the common map targeting and pure trial and error parameter adjustment compared to the previous. Interestingly, we also see the selective improvement of the OCD symptom without any impacting mood and anxiety change. Previous literature, they report that when the patient showed the Y box improvement, it also changed the depression and anxiety score. However, our results indicate that selectively only improved the OCD symptom without depression and anxiety. Lastly, we did the stimulation model. We used the pre-superpatialization. Finally, we ending up 48 ROIs from the whole brain, and we did a repeated measure correlation. And here is the results. The 10 out of the 48, 10 ROI regions show the significant correlation with the Y box improvement based on the FDR collected. And we found that dorsolateral and ventrolateral prefrontal and thalamus STN and lateral and medial midbrain lesion. Based on using this 10 ROI, we did the prediction stimulation model. As you see in this figure, the empirical Y box score improvement is highly correlated with the predicted Y box score. However, this same method we apply the BDI and BAI, depression and anxiety score, it doesn't work as a Y box improvement. So finally, we built the updated common map using all of the cohort A and B, and this updated common map agree with the initial common map we built it using 3T data. Now this is a 7T data. It showed the ventral lateral frontal and ventral medial frontal and thalamus and STN and brainstem is associated with the OCD symptom improvement. So here is summary and conclusion. We built precise ALIC DBS targeting method using patient-specific tractography, and we stimulate at the confluence of the prefrontal and the midbrain fiber. This method giving us the best and consistent and specific improvement of the OCD symptom, and tractography-based stimulation model predict the Y-box improvement. So our conclusion is that we establish predictable and implantable patient-specific tractography-based DBS targeting method for the refractory OCD patient. So here is unfortunately, didn't make it our primary author figure, Arba. And thank you for your attention.
Okay, so we have one question in the app. So the question is, does different diffusion MRI acquisition or analysis severely change the result?
Good question. So primarily we use, to build a common map here, we use the FSL probabilistic tractography. And we also tested like MR3 or some other method here. Definitely there is some difference, it exists. However, primary binding like a ventral medial frontal, ventral lateral frontal, or midbrain connection is still there.
I was wondering, I mean, very interesting talk, but so when you look at the confluence of these three fiber tracks, I would imagine that the overlap can potentially be quite large in some individuals, so there might be multiple potential targets for your DBS electrode. So how within that the overlap region do you determine a specific point? What other criteria are used? Or is that confluence a very spatially confined?
Actually, that's a very good question, and then it really depending on the patient. Some patients showed a very narrow, just one spot in the around the ALIC. Some other patient, it showed a broad, like a very big lesion around the ALIC. In that case, it requires some of the anatomical, like the limitation or restriction. So basically, how like not only this the OCD, all of our diffusion tractography-based targeting that we develop it using depression and OCD or essential tremor. First, we start from the anatomical constraint. For instance, the ALIC is definitely first start around the nuclear commons, ventral striatum area, and keep moving back posterior to see the GPE coming up. So it really depending on the subject, but most of the case, around 80% of our targeting case, it only gives us a one spot.
Right, right. Thank you. Any other questions from the audience? Oh, I think we've got one.
Thank you for the great talk. So I have one question about like side effect. Do you find any kind of differences between this track in terms of like hypomania or mania or other side effect profile?
So far, we don't see the clear side effect with this patient unless we really give them like a nearly high amplitude. We started with around 4.5 milliamp at this point. However, sometimes we go up to the around 6. Once we gave them, definitely we do the bunch of other experiments here, is the LFP and the behavior task or something. So sometimes we gave them really high amplitude. In that case, we see some kind of one you mentioned, mania or something. However, typical our standard amplitude, we don't see the lots of the adverse effect.
I think that will be all for this speaker. So if you have further questions, you can always approach the speaker after the oral sessions.